Good afternoon. I'm Linda Baker, the Learning Director at the Center for Research and Education on Violence Against Women and Children. On behalf of the Knowledge Hub team, I would like to welcome everyone to our first Hub research briefing, the Flourish Project, Collaborative Approaches for Supporting Survivors. Today, our presenters will speak for about 10 minutes. Please enter comments or questions for the presenters into slido.com using the code that you will see on the slides when the presentation begins. During the last 5 to 10 minutes of our research briefing, I will present your questions to our presenters. The link to the presentation slides was emailed to you earlier this morning. I'm pleased to introduce our esteemed speakers. Wangari Thararo is the Director of Research and Programs at Women's Health in Women's Hands Community Health Center. She is currently the North American co-chair of the UNAIDS NGO Delegation Program Coordinating Board and is a co-founder of several local, provincial, national, and international networks. Her co-presenter, Muna Aden, is a research and program manager and consultant based in Toronto. She is a member of a provincial research team investigating the prevalence of HIV and associated factors among key populations. Muna is a community advisory board member of the Because She Cares project. Please join me in welcoming our speakers.
Good afternoon, everybody. As introduced, my name is Wangari Thararo, and I will be presenting on the Flourish project with my co-worker, Muna Aden. Our presentation is based on a multi-year project that was funded by the Public Health Agency of Canada and implemented by Women's Health in Women's Hands, a community health center that works with racialized women in Toronto. And we work from a feminist, pro-choice, anti-racist, anti-oppression, and multilingual framework using an intersectional approach that integrates the determinants of health of importance to racialized women. We've been working around FGM or FGMC with women advocates and leaders from affected communities since the 1990s. We actually implemented the first training program in Canada for service providers in 1991-92. When the government of Canada stopped funding this work, most of the programs, including ours, actually ended. And we were gratified to actually receive money to implement this program. We would like to start our presentation by acknowledging the team that we worked with, our two staff who implemented the project for the 3 years that we were funded, and the community advisory committee that we worked with, as well as the GenderNet Plus research collaborative that works is implementing research on FGMC. Next slide, please. Many of you may not be aware that FGMC is or more than 200 women, 200 million women and girls have undergone this procedure, and it includes removal intentionally to alter or cause injury to the female genital organs for non-medical reasons. And it has no benefits whatsoever for women and girls who have undergone the procedure. The project aimed at supporting survivors of female genital mutilation at the community level. And over the entire program, we created tools and resources which we hope will be utilized by those affected by FGMC and those working with them. Next slide, please. The go back to the other slide, Muna. I need to talk about the objectives of the program. And it was to develop a service provider framework, develop a sustainable network of community leaders and organizations to support FGMC communities and women who have been affected, as well as development of resources for survivors, as well as the media, to strengthen the voices of women and their communities to actually speak against the practice and work towards its elimination. Next slide, please. We had a lot of activities funded through the program. We conducted an environmental scan with about 84 participants, which included a survey, focus groups, and community workshops. Participants included survivors of FGMC, affected women, service providers, including physicians, nurses, social workers, and sexual health clinic volunteers. We created an advisory committee that comprised of community leaders and organizers, survivors of FGMC, and individuals who are interested in this work, including students, arts-based experts, as well as program participants. We consulted with more than 100 community leaders, service providers, religious leaders, and organizational representatives in order to get a clear understanding of what is happening within the communities, perceptions around the practice, as well as gaps that might exist in service delivery. We conducted many outreach activities at various events, including on the International Day of Zero Tolerance of Female Genital Mutilation, International Women's Day, and other awareness-raising activities reaching hundreds of people. We held 6 arts-based workshops focusing on storytelling, with 2 digital storytelling workshops to build resources based on experience of going through the procedure. We developed a trauma-informed service delivery framework and held 3 interdisciplinary trauma-informed service provider workshops. We wrote an FGMC policy paper to inform actions moving forward. And we're going to assemble all these resources into a toolkit for distribution to different stakeholders. Next, please. Among the service providers who participated in the survey, 61% indicated they had encountered women with FGMC, and 23% had encountered clients with complications due to FGM. 46% of service providers surveyed indicated they were not so confident in providing care related to FGMC, and 30% were not confident at all. 74% of physicians and other care providers felt undertrained, and 93% desired training opportunities. And Muna, my colleague, will take it over from here.
Thank you, Wangari. The second half of the presentation will continue the dialogue on knowledge generation and also touch on some findings in strategic knowledge exchange activities. In addition to the survey, we also gathered qualitative information for the environmental scan from 6 focus groups with survivors of FGM. A few themes remained consistent across all 6 focus groups. These included sexual and reproductive health, interpersonal relationships, women's healthcare experiences, and mental health. I'll touch on a few of these in the following slides. In terms of sexual and reproductive health, difficulty during pregnancy was a common theme, with some women linking FGMC to complicated pregnancies or miscarriage. They also discussed the process of FGMC in great detail and could recall the various stages across their lifespan where FGMC intersected. For example, being cut or sewn closed as a child, reopened at the age of sexual debut, de-infibulation during labor, or re-infibulation post-labor. Participants also expressed interest in clitoral reconstruction, but were wary of the expensive nature of such procedures. With respect to mental health, the lack of FGMC-specific mental health supports was discussed widely, with some women expressing their desire to access counseling to treat early childhood trauma as a result of FGMC. The impacts that emerge often cross-cut psychological, social, and physical. For instance, emotional trauma could be triggered by daily interactions and activities. Urination could be a simple daily reminder that other women don't have to deal with this. Having negative interactions with healthcare providers was also mentioned as a triggering experience, as was experiencing loss of community due to migration and feeling generally looked down upon. Over the course of this project, it became clearer to us that allied health workers, including doctors, nurses, and social workers, were often unaware of the many negative health consequences of FGMC, and many remain inadequately trained to recognize and treat the health issues of FGMC survivors. Survivors themselves also spoke to this and specifically mentioned their experiences with family doctors, gynecologists, and social service workers, and the feelings of inadequacy that they experienced in those interactions. So to sum up these activities, we invited approximately 75 participants to attend a capstone service provider training, which aimed to promote knowledge exchange among service providers. Attendees included physicians, nurses, social workers, and health promoters from across Ontario. Knowledge brokers included global experts and local experts in FGMC, and the training integrated all of the knowledge generated throughout the course of the project and was delivered as a full-day program. 92% of participants reported changes in knowledge as a result of the full-day training and stated that they would incorporate the knowledge gained into practice, including increasing their knowledge of FGM, as well as the care needs of women who are survivors of FGM. They would also work towards creating safer spaces for clients to share their experiences and work towards culturally and gender-appropriate responsive care. They also discussed stigma and reducing stigma in their practice and at other organizations, the need for a trauma-informed approach, as well as training and capacity building for their colleagues. 84% of respondents found the knowledge product or the event itself was valuable, and 73% of those attendees believed that the content that was shared with them achieved an appropriate balance in addressing their needs. So some of the learnings from this process that has been helpful for us as service providers and community-based researchers include, how to use and understand data, but also listening to people's experiences if and when they diverge from the data, integrating formal and informal feedback as a mechanism, and educating providers of all stripes on social and institutional barriers. And the main piece that we took away from this experience was centering and leading with the experiences of people with lived experience of FGM. To that end, we're going to continue to conduct research with our partners. We will advocate around access to care and reducing barriers identified in the qualitative research, with a specific focus on confronting anti-Black racism and using anti-oppression and trauma-informed guidelines to promote cultural safety at all levels. We're also finalizing, as Wangari mentioned, the dissemination of our media toolkit, which will include all project materials to be shared widely. And we will be also publishing our policy paper, which we have completed, and look forward to identifying greater resources to help promote sustainability. So with that, we've come to the end of the presentation. Are there any questions? And thank you all.
We do have questions, Muna and Wangari, and I'd like to just not waste any time and jump right into them, if that's okay with both of you. One of the first questions is, can you expand on how the large number of service providers were involved in the project?
I can respond, Wangari. So we had service providers participate with the project at all stages, similar to our approach with community members. So we had service providers as part of our advisory committee, They helped guide our project from the very beginning. And we also have deep networks as a community health center with providers who provide women-centered care. We also used our connections with women-centered research centers as well. And that's how we were able to recruit people who were experts in the field. And one of our strongest partnerships is with GenderNet, which also includes a large number of service providers.
Thank you, Muna. Another question is, did you find a link between young women and girls who are survivors of FGM or carving and being sex or labor trafficked?
We had, I'll answer this one, Mona. We actually, the digital story telling workshop that we actually did was most of the participants were actually young women, and they wrote about their experiences of the practice being taken from here and then returned back home where the practice would be done without their knowledge. They just thought that they were actually going to visit the extended family, but had the procedure done while they were there. So the most of the participants actually came here or were born here to families from affected communities. So we didn't really encounter young women who had been trafficked, or the data we generated did not highlight that experience.
Thank you, Wangari. One of the questions is, if you just could name a couple of things, what is it that healthcare providers absolutely need to know when receiving patients who are survivors of FGMC?
I think one of the, and I'll say something, Muna, and then you can add on to what I say. I think one of the most important things that that was highlighted is service providers actually knowing what FGMC actually is, educating themselves, finding out what are the implications for women who are affected by the practice, and also understanding that they will require specific procedures during delivery and during birth, so that they can actually support them much more effectively. The other piece we learned is that women wanted to be treated with respect. Respect that you respect their culture, you respect their who they are, their self-identity, and will treat them the way you would actually treat a person who comes from your culture who is entering into the healthcare system. So respect and understanding of what you need to do with them in the context of FGM, that you don't expect them to be educating you what to do as a provider. You ought to take that journey by yourself. Muna, anything else that you want
No,
to
you
add?
summed it up wonderfully.
I wonder if you could explain a little bit what you meant by sometimes women were unknowingly forced to disclose FGM. Can you give an example and help our audience understand more clearly what you mean by that?
Yes, so disclosure in the context of sharing information with your service provider is an expectation that women often are used to. Some women in our focus group describe instances where they were forced to disclose to service providers that were not their own, either as a teaching opportunity for other providers that happen to be in the center, or as a result of insensitivity on the part of their primary provider, who would call in an assistant to come and take a look at the client's examination. So these were often traumatizing experiences for the women. So when I say forced disclosure or inadvertent disclosure, it's disclosures that women were not prepared to make to anyone other than their primary provider.
Thank you. That does clarify it. You mentioned, we're just coming to the end, and you mentioned the toolkit. And a lot of the focus groups and some of the training you've done was in Ontario. Is it going to be available nationally and beyond? And if so, how do people access that? Or will they in the future? How can they access it?
Yeah, so go ahead.
It's okay. Go ahead. Go ahead.
We hope that the toolkit will be accessed widely, locally, nationally, internationally. We're working with other service providers who are doing similar work as well, and we hope to share our findings with them to help along their process. And once it's ready, we're trying to make sure the imagery and the delivery is absolutely perfect before we launch it. And it will be accessible on our research website, whiwhresearch.com.
That's wonderful. You are our inaugural pair to share a research briefing, and it truly is a rich nugget of findings and education. And we hope that people will go to your website to learn more. And we also hope that people will stay tuned. We have another research briefing on Thursday at the same time, and then they will occur periodically throughout the remainder of the year. So Wangari and Muno, thank you so much for this presentation and for answering our questions, and to continue the great work that you're both doing along with your team and your partners in the community.
So thank you very much. We also appreciate the opportunity to actually share the findings from our project, and you have given us the perfect platform to be able to do that.
Oh, thank you, Wangari. And we hope everybody will go, because this is a new series. Please go. There will be an evaluation link that Sarah's going to send out to everybody, and we would like your feedback. And with that, we'll say thank you and goodbye.
Thank you.
Goodbye.